Good evening, everybody, and apologies for the delay. Today we had to sort out a few technical issues, but nevertheless, it's an even greater pleasure to welcome you for tonight's ESTS webinar on behalf of the ESTS Committee for Learning Affairs. I'm very happy that we have two speakers today for our topic, overcoming hurdles in thoracic surgery training, including grads in the general thoracic curriculum that really don't need any invitation. We have Isabel Oppitz, our current ESTS president, professor of thoracic surgery and head of the department at the University Hospital Zurich, and Robert Zofolio, who I think performed probably worldwide the most robotic procedures and really trained uncountable numbers of thoracic surgeons in robotic surgery. And I'm really happy to have them both here to present the European and the North American perspective. And we're looking forward to very interesting presentations and good discussions. As always, I invite you to ask your questions via the chat function, and we'll have the discussion after the presentation. So ladies first, we have Isabel starting off with her presentation, and we look forward to it.
Thank you for the kind introduction, Clemens. I will start sharing my screen. Let me know if you can see the slides.
Yes, we can see the slides. You just have to switch to presentation mode.
I actually did, so let me try one more time. No, it's not. And can you see it forwarding?
We can see it now. We can see it in the working mode, but the slides are here.
Yeah. Okay. I think we had enough. We had enough hurdles. That's good because that fits into my talk. I will just continue like this. Overcoming hurdles in robotic-assisted thoracoscopic surgery in the general thoracic curriculum. These are my disclosures. I'm an intuitive proctor, which I would like to point out for this talk, but I'm confident to give this talk without any conflicts of interest. So I will speak in the next 15 to 20 minutes about institutional approaches for teaching robotic surgery, about society approach, and then a few global challenges in robotic surgery training. So when we talk about components of robotic surgery, there are several of them that are available. So one of, to start with, are online modules. I will not speak too much about this. Then there are virtual reality simulator training platforms, then a supervised bedside training, and then to start with the actual cases with more basic and then advanced ones. I'll show a little bit of the literature, which is in accordance to also what we do here at our center. And then at the very end, I'll come to the institutional perspective. So let's start off with the simulation training. There are several simulators and platforms that are available, such as the one from Intuitive, but there are also other platforms that are available like SimSearch, educational platform, or others that can be used for this. And there's always a video library that is available for simulation of anatomical lung resections. I can only recommend Dr. Zofolio, who will speak after me, has produced large libraries for this purpose. And then there are indeed important factors that cannot be actually practiced, that is safety in the operating theater. And you can see here a publication from Dr. Jean-Marc Bast from Rouen. I will come back to this later, who has implemented a crisis training in the operating theater to improve safety and performance. And you can see here only a snapshot of how this works. So this is including several disciplines and professional healthcare groups. So besides the surgeons, the anesthesiologists being super important, and also obviously scrub nurses and other in the OR. The next step after the simulation is the supervised bedside training. So not really bedside, it's an OR side training, which can start off with inserting trocars, docking the robot, inserting and exchanging instruments, and then also assist the console surgeon in retracting and suctioning and achieving hemostasis by having an additional access port. It's also an option to have the surgeon at the OR table actually doing the dissection or with the staplers, with conventional staplers. I always feel that this is a great training also for the surgeon for minimal invasive techniques if they can do this. So there are a few publications that I would like to come to talking about how to train residents in robotic thoracic surgery. They're always talking here about this Q-sum, how it is called, cumulative sum analysis, which is kind of showing actually how long and how many procedures you need to master an operation. This is an example of Southern California robotics curriculum. It's including all these components we've been already talking about, and it is besides the different simulation components, including cases. And here I think it's very important, and that's nicely also pointed out in this publication, that there are indeed different level of operations, how you should start to train your residents and fellows in this operation. Here they divided in several levels and have level 1, 2, and 3 operations, whereas lobectomy and segmentectomy or sleeve resections, esophageal resections are the most advanced ones. And I think it's a good way to start maybe with a simple wedge resection for the handling. Another next step can be the dissection of the lymph nodes, like shown here of the station 4R, which is dissected to get a better feeling for the tissue. We usually use as the next step the rat's thymectomy as a procedure that can be mastered. And then there are different approaches of how to learn a lobectomy. Maybe you can start off by taking the vein, and then subsequently master the following steps in later operations. And you can see here, this is, for example, an example from the French group, also led by Jean-Marc Bast, who kindly provided me these slides. They have an anti-clockwise dissection of a lobectomy, which means like coming from posterior up to the lymph nodes and then to the hilum. This is what naturally most probably all of research of robotic surgeons are doing, but this is how he teaches this in different zones, very let's say standardized, in a very standardized way, and also having here for this a structured evaluation form, which also gives the opportunity for the trainer and the trainee to assess the performance. So when it comes then to more advanced cases, like for example, cases like this here with a post-induction, not only chemo, but chemo-iotherapy with big lymph nodes being left behind. And you could see here at the pulmonary artery, you see also fibrotic lymph nodes, which can become a challenge during the dissection. Then what is recommended for these more advanced cases, when you start with those, to take here some security in dissecting the main pulmonary artery and the veins to control the blood flow here and have a more security in case you come into trouble. For example, in a dissection here with the bronchus, which is actually stuck to the pulmonary artery. Also here, I would recommend, as you can actually clearly see it, that you have an experienced surgeon helping you for these cases. You can see he's practically operating with the suction and helping. So this is something that is also, when you kick off with these more advanced cases, to be recommended. And then there are also very challenging, sorry for this, not presenter mode, cases with huge tumors in the posterior mediastinum, where I personally feel it's a very elegant way of using the robotic, but you can see here clearly it's actually pushing the left atrium forward and can be quite challenging and maybe not the case to start off with. You can see here, this is the post-resectional view on the left atrium. So in putting this into numbers of how long it actually takes to learn lobectomy, there have been very nice systematic reviews. This one is from 2020, where 2,316 records were identified, and you can see the learning curve for duration of surgery, length of stay, and complication rate was here specifically giving for lobectomy and thymectomy, and the numbers of procedures to overcome this learning curve was given for 15 to 20, and for lobectomy also for 15. And there is a more recent publication that is from this year, actually also a systematic review and meta-analysis. And here you can see all over these different publications assessing the learning curve for robotic lobectomy. They come up with a number overall, these publications of 25. So all this is numbers and procedural steps that can be implemented in your institution for training your staff in robotic surgery. But there is still, I think, a role for the society besides the commercial platforms for training for robotic surgery to implement a curriculum. And that's what we set off at ESTS a couple of years ago and invested a lot of time and also money now to establish the first society-based curriculum for robotic surgery. And you can see here, this is a one-year program which started off already with the first 8 fellows this year, and there is several components that are actually exactly the components we've been mentioning before. You have an e-learning platform, then there is this comprehensive safety program, which is happening in Rouen. I will come back to this later. There will be a European tour through different centers as an observership, and also at the very end, a fellowship of 6 months at one of these institutions. So the first step was, and already happened, that we had a wet lab course in Orsi in Belgium, where we had a 2-day course, and that was the faculty being involved, all experienced robotic surgeons. And it was a very nice experience for the 8 fellows, because besides the usual simulation, they really had real-time exposure with kind heart and pig cadaver, and also real cadaver settings for lobectomy and thymectomy. For those who don't know the kind heart model, that's a heart-lung block which is perfused with theater blood and is very good for training lobectomy. This is the faculty, how we were there the 2 days, and we really enjoyed the time with the fellows, and I think they also had a very good time and a very good exposure. So the next step for the fellows is going to be the Rouen safety course. I was touching base earlier. This is the faculty from Rouen, and they have a 2-day program where it will be a lot of real-time in the OR, where the different teams are involved. And there is also a live case that's going to happen. And then this all is accompanied by a series of webinars we're giving. The one today is not counting for this. There are 3 different coming up in conjunction with STS. Besides these non-technical skills, safety training, there will be a webinar about thymectomy, and then another one about segmentectomy. And then these fellows have these centers to choose where they can spend 2 days. They can actually go to 2 centers. And after they have been spending their days there just as an observer, they will have the opportunity to spend 6 months also at one of those centers as a robotic fellow. So this is our first year. We're running the program, and it is so far being very successful. Obviously, we will wait for the feedback from the fellows and also from the trainers after this first run, and to further improve the curriculum and even broaden the access in Europe. In the last 2 minutes, I would just like to point out a few hurdles indeed, because so far we've been only talking about how you can do it, but there are some hurdles in training thoracic surgery in general. And one of the most important one is indeed the working hour restrictions, such as an 80-hour work week, which is for sure not a European situation. Is this really enough to train a doctor? I will leave that question open. And then there is another problem, that we slowly have an extinction of open surgery. And this is what we can observe, what already happened quite a while ago in abdominal surgery, where you can see here that 29 residents that have been followed over a period of 2.5 years, they had only 0.86 open cases per year, which would mean a resident would wait in the future 1.5 years to do an open gallbladder and 5 years for an open appendix. I think we're not near that, but maybe slowly moving into this. I can tell from our personal experience here in Zurich, mostly thoracotomies can be done during lung transplantation, but there is rarely an occasion for really thoracotomy for our residents. And then there are other challenges. I've been briefly touching the problem of, let's say, increased technical challenges in dissection for after new perioperative targeted or immunotherapy, which might increase the complexity, at least as it has been shown in some of the trials, the NeoStar trials or the Cornell experience, where they have been showing moderate to severe fibrosis after induction IO. It can be very difficult. It can be very normal. It's very difficult indeed to predict, but I think it's at least not a very first case to start with. And then there is also more knowledge asked for our residents and trainees. So current trials that are going on, the testing for targets, etc. Just to show a brief snapshot here, these are the available treatment for non-small cell lung cancer in advanced and early stage disease. So all of this needs to be learned and studied by our trainees. So let me summarize and conclude to be in time that we still see further increase and widespread of robotic surgery within Europe, within the global stage, and board exam requirements and teaching programs need to be adapted accordingly. And this is not only the institutional, but also professional society responsibility to come up with curriculums that are robust, multifaceted, including the didactics, observation, simulation, and hands-on performance. And with this, we also have to respect the challenges that are working hour restrictions and the spectrum of closed chest, open chest surgery and the new complexity degree. And with this, I'm very grateful for this opportunity today here to speak to you, and I really look forward to hear from a world expert, Dr. Sofolio, about his experience in robotic surgery, and I'm sure he will show some very fancy videos.
Well, thank you very much, Isabel. That was fantastic. Now, I'm going to try not to, because I think what I want to deal with is what are the challenges people are seeing out there, and I think a lot of them are leadership and politico and money and access. So we'll talk about that. I'm going to share my screen. Let's hope this works. And share, and then I'm going to go into. Is that working, everyone?
Yes.
Okay, great. And you can see it in presentation mode? Yes?
Not yet. Maybe Isabel, can you stop sharing your screen? It's now in the working mode as it was with Isabel.
Okay, let me try it again, because I have it on my mode. It's in presentation mode. How about
that?
I
had the same.
Okay, well, so it is. So financial disclosures. So I don't have any financial disclosures. I was executive VP and COO here for 5 years. They don't allow you to have any type of conflict of interest. And I was a dean, so I don't have that. And now I have not re-signed that. I'm no longer COO. I'm now head of quality and director of efficiency and quality for our system. But I have maintained no relationships with Intuitive or any other organizations. I do have to put my book. I have a few books And I would tell you the only reason to put the book up here is because I think this tells you a little bit about what we need to do as a society, and that is really train ourselves mentally and physically. This is my cell phone. I give it to everybody because I work for you. I'm now 60. I've got 15, 20 years left. I want to make sure that I serve all the colleagues in our department, in our division, and in the whole world in heart and lung surgery, really all surgeons, and really even all doctors. So please use that email below. Use my cell phone. Take your phone out. Take a picture of it. Feel free to WhatsApp me or email me if you're having problems. And I've written 2 other books, and these are my only conflicts. So technical training.
Sorry to interrupt. Currently, I can still see your first slide. So it doesn't change. Probably you stop and reshare your screen.
So I don't know why that would be. So I'll stop sharing. I'll try. Thank you for telling me. I'll try sharing again. I'll go to window, and I guess I'll go to this screen. Is that working? No, that looks worse.
We can see your entire screen now.
Yeah, which you really don't want. Very frustrating, isn't it? Doesn't make sense. So if I hit share screen in Windows and I hit this, you're not watching this screen here. I'm moving now. You don't see the slides moving?
No, at the moment we can't see your screen at all.
Okay, we'll get it. Give me 10 seconds. Hang on 1 second. Call Rosie Infanti. Let me have my IT person come in here too. That'll help us.
Maybe we can give the good news.
Yeah, maybe the group wants to ask a few questions to you, Isabel, while I figure this out. Let's do it.
Yeah, maybe we can start a little bit the discussion. So I found your numbers so impressive. Can you comment a little bit on how many cases you are doing? I think this is also important for the audience that they put it into perspective that this is not a very everyday setting that you are having.
Yeah, so I've done 18,800 operations and then 2,550. Today was my 2,550th robotic case today. So I've done personally over 1,000. That just means I've been around and haven't been injured. That's all that means, Isabel. But I think we've learned a lot. And I have a partner, Dr. Zervos, who has done almost 1,900. So between us, we're at, coming up to 4,000 cases. Every case is done robotically. See if you can share my screen, Matt. And I'll let Matt, who's got a beard and is better looking than me. When you did this, it didn't work. So that doesn't work. They didn't see it. So you got to share this screen. No. Okay. So, we do every case robotically. We try to remove the tube before the patient wakes up. So we're trying to have patients wake up with no chest tube, and everybody is trying to go home in 23 hours. And that's kind of our goal to do. And we haven't had a conversion in a long time. You think it's working now?
Looks like it's sharing.
It's sharing, but we want presentation mode.
And you have, and maybe just final words, how many robotic platform, how many robots you have?
Yeah, so we have 22 robots. It won't work on this screen. We have 22 robots in our institution. We have 11 at our hospital here, 22 throughout the whole healthcare system. And that's just intuitive robots. That does not include our other robotic portfolio and platforms that we have. All right, is it working now?
Well, it's still the same as it was before the first slide in the working mode.
All right, so here's a good thing. A good speaker doesn't need slides. I'll do it without it. The problem is you can't see my cell phone and email. Well, I'll give you my cell phone. You ready? Matt's not working.
Yeah.
All right, never mind. 205-612-18.
You can see it. You can see it.
You can see it?
Yeah.
Okay, good. Those are the books. And we're going to say exactly what you just heard Isabel say, and that there's no homogeneous protocol for robotic training. It's unfortunately promulgated by industry, not by societies. But over 15 years, I've had the honor to train almost 1,000 surgeons now. all the way from medical students to full professors. And that training has to be different, right? You have to talk very differently and be nimble and individualized coaching and dynamic. If you're going to talk to a 63-year-old department chair who's used to doing VATS and seeing the whole operative field from the front instead of the back. You know, Isabel, you touched on this. Everyone can see my slides right now? Yes?
Yes.
Good. So look at the last bullet, which should have been custom animated and come in at the end. But the view of the operative field is critical. So if you're a VAT surgeon and you're always used to looking at the front and taking the vein first, and then the artery, and then the bronchus, you are really going to struggle with post-chemotherapy and immunotherapy cases, because you got to cut the airway in half to get those cases done. The artery, the pulmonary artery and the airway are literally socked together. So it's very, very difficult to do it that way. The other thing is I see people flip the lung. They flip it once. I told my resident and fellow, we don't flip the lung. You don't get it. There's no reason to ever flip the lung. You got to know the anatomy from the back and from the front. We do most everything from the back. And we do try to take the vein, not always first, but last. I'm not sure about this data of improved survival, taking the vein first. You have to be very careful interpreting that data. So I think everybody has a different dogma. Everybody has a different mindset. And I, as a teacher, have to set myself to that. This is a slide I do want people to take a picture of. I'm really disappointed it's not custom animated because I want to go through it 1 through 10, but I have to live with the technology. So the first important point is the surgeon has to want to do it. I saw all these wonderful friends of mine. Maria Teresa's on here. I saw Sergio Alonso and others. And, you know, they're great at what they do because they had passion to do it. Your mommy can't want you to do it. Not your daddy, not your chairman, and not your hospital CEO or COO like I was. You have to want to do it. You have to see that it's better for patients. It clearly is. I don't need data to prove it. I know it is. I knew it was in 2009 when I started doing it, and everybody laughed at me, and now we're showing it. But I certainly know it's better for surgeons. And again, that's who I work for the most, are surgeons. My surgeons are more comfortable. They have less pain. They're sitting, they're not standing. If they get hurt, if they're pregnant, if they have an injury, whatever it is, they can operate longer and have less pain. That's what I care about. So I call this a 10-step training process. First of all, there's simulations, as Isabel said. If you don't get 75% on all the exercises, you can't sit in our operating room. The second is you have to know all the bells and whistles on the robot. You can't just press buttons and not know what they do. Then you have to learn the available instrument and options of the setting, how to turn Firefly on and off. You need to do Fireflying to really look at the segmental fissure and anatomy. And then learning the anatomy, number 4 should be 4, 5, 6, 7, 8, 9, 10, 11, 12. Because I have met very, very few surgeons who really know the lobar and sublobar bronchial and arterial and venous anatomy, especially in the lower lobes, especially on the left. It can be very tricky and they're very variant. You have to know it. And then I think that one of the things I would add on to what Isabel said, and Isabel, your talk was great, was the team training. The teams must go together, not just the surgeon, the anesthesiologist, the bedside assistant, the surgeon, yes, the anesthesiologist. And then you got to go a place to visit. We've had hundreds and hundreds of people when I was in Alabama and now hundreds in New York City, so over 1,000 visitors. All of my videos are on YouTube, so I'm not going to take the time today. You can go watch them. But the key is to carefully look at them and see how many times we cut the airway in half with a bipolar. And when I hear silly questions like that causes infections, why do you do that? That doesn't even make sense, because every transplant would get infected if that's the case. Obviously, cutting the airway in half has nothing to do with infections. It has to do with safety to separate the airway from the pulmonary artery. Then you need to pick a mentor, and that mentor must be a counselor, a coach, and more than mentorship. And then you have to have a proctor who uses the same technique as the mentor. And many times they don't. I'm a 4-arm technique. I usually go from the back. If you have a proctor who's a 3-arm, if you trained on a 4-arm, and then when I do it from the front, it's a little bit different. And then the other mistakes I see is people get trained and they go back and they have no cases. They have no patients ready. So you really need to be thoughtful about how you're going to do that. So what are the challenges, as Isabel said? The first one is access to the robot. As you heard, we have 22 robotic systems here at our institution. I get one every day. I operate. My partner gets one. We have 2 every day in thoracic surgery, and we have 1 every day in cardiac. So just the department of cardiothoracic gets 3 robots a day every day. We're soon to have a 4th. So access is when you can't get good at something if you can't practice. I don't want to hear about hours. I want to hear people who want to work and get better. I'm not interested in the other nonsense. Number 2, lack of knowledge of anatomy and lack of awareness. I have many surgeons tell me how well they know the anatomy. When they come and visit us, I ask them a few questions and they don't know. They're not really aware of where the A2A or the A2B may come off, or where the V2 turns into the central vein, especially if you're doing something like an S3, where you have to complete the anterior fissure first to really do an S3. And then a lot of surgeons, I think, are afraid of changing. I keep hearing how well they do stuff, and why would they change? Because their patients do well. Well, we're not using a chest tube now. I just started that a month ago. So our patients did well. We have had no 30 or 90-day mortality in 5 years. They all go home in a day. We can do better. They can wake up without a tube. So you can always do better. When I start to hear how good people are, I need it's time to go on to the next person. Low volume of patients is an issue. Different teachers and techniques I measured. And then a lack of dedication. People get burnt out after a while, or their team makes it too hard. The anesthesiologist wants to use an A-line, or my God, they want to put a Foley in, or they want to type and cross and type and screen. None of those things are needed. And so all of these things slow you down. So it's about training your team. I invite you to have your anesthesiologist come and see how we do these with a peripheral IV, and the people wake up with no tube and go home that night or the next morning. And then I watch people get frustrated because I don't have patience, as you can tell, but no one does. And as they go through the learning curve, it's hard to go backwards if you're really good at VATS or really good at open, but eventually this will make you better and your patients better. Or there's a lack of support. The chairs that don't do robots must support the younger surgeons who do. And I have younger surgeons who are doing things that I can't do. I have one that does ECMO. I can't do it. I support her. So I think it's contingent upon culture and leadership. So I just want to talk a little bit about leadership at your organization. You have to be accountable. There has to be ownership, and there has to be positive encouragement. And I won't talk about the EQI today. Importantly, I think when we're coaching, people all have a style. I have a certain style that people may or may not like, but I can change the style based on how people get coached. So like there are love languages, I try to recognize my mentees' coaching language. Do they respond best to words of praise? Do they respond best to challenges and competition? Do they respond to evidence-based data, et cetera? Everybody has different coaching languages. And I think you're not going to become a 3-star lobectomy, as we program in the STS, as we have been now for 6 years in a row since the 6 years I've been here in New York, unless you can make all 8 of your colleagues, we have 8 lung surgeons here, buy into your love language. You got to be tough on standards, but soft on people. All of us fail. I fail every day. But as long as I want to get better, I think that's the most important thing. And then it's time and dedication. It's sitting side by side and really loving the person you're teaching and caring about them and loving them the way you do your family, the way you do your children, and spending time to do it. And then standardizing everything. Here we have 3 visitors watching us remotely with one of these systems. We can do remote presentations anytime you want. And it's about teamwork, having the anesthesiologist, the nurses in the OR, the nurses in the recovery room, who now see people without chest tubes and wonder if they can go home from recovery room. They probably can. We're probably going to start doing outpatient robotic lobectomies and segments like we do with thymuses. Again, you can make your time before you start faster and your intraoperative process faster. Here's an article just looking at what we did before we made incisions. Here's us teaching in a lab. Here's us breaking down a lobectomy into 19. We actually had 48 parts. The reviewer made us make it 19 parts, but we can teach lobectomy and maintain quality by saying, okay, here's 19 part. Taking down the ligament should take 45 seconds. If you can't finish it, I'll finish it, and then I give it to you for the next part, taking out the number 9 and number 8 lymph node. That should take about 20 seconds. If you can't finish that, I'll finish it. We'll go to the subcarinal space. On the right side, that should take about a minute. On the left side, about 2 minutes to get them all out. If they can't finish it, I'll finish it, and we move on. So this keeps us very efficient doing the operation. And I think leadership is like golf. You have to know what club to use, but then you have to know when to use it. Which club works in which situation, in other words, on which trainee. And I've done this with my children. I always have to have my children in my talks because they all were, Division I athletes. But you did this all the way from when they were little kids, like you show here, when they're 8, up until they're pitching in college. And again, it goes back to how you inspire them, how you get support from administration, money, and what kind of language you use. That makes or breaks if you get that extra robotic system. So I think in the future, we're going to track all metrics. We're going to be more granular. We're doing it now. We're looking at hand movements, operative times. If you don't finish the lobe skin to skin in 2 hours, we say, okay, it's a violation, but why? Was there economy of motion here? Was the conduct of the operation optimal? And I think the conduct of the operation is the single most important thing to talk about next. And then we have procedure-specific simulations, cognitive metrics. What are people thinking about? How are they doing emotionally? Behavioral and emotional metrics we're measuring now to really make sure people are engaged. The future is going to break parts of these down where the robot's going to do parts of the operation for us. And it'll never work if we're not aligned. If we're losing money, this will never work. So we make money by reducing our costs. The number one cost, of course, is operative time and length of stay. Well, if they all go home in 12 or 23 hours and your operation's under 2 hours, you can make 70, 80,000 American dollars per lobe, even with non-commercial payers. So I'll quickly end with a study that we're looking at. This is my own consecutive series. This does not include my partners. These are 1,500, over 1,000 lobes and 450 segments that I've performed over the last 11 years. Every patient was done robotically, so there was no selection. Even if it's a gigantic mass, we start off robotically, and if we have to open to get it out, we count it. The goal is to do them all robotically. Everyone goes home in a day, and to have R0 resections and to measure patient experience. I give every patient my cell phone. What did we find? Well, over time, we couldn't do them all robotically. It was only 50%. We were opening a lot in the beginning, and now we don't open at all. The conversion rate is essentially 0, 1 in the last 400. The 30-day morbidity, major morbidity, is literally less than 1 in 1,000. So pneumonias don't happen, AFibs don't happen. All this stuff goes away. And the 30 and 90-day mortality is 0 for our last several years. We haven't had a 30 or 90-day mortality. And that's related to short, quick operations, and then sending people home with a pulse oximeter, sending them home with a thermometer, transferring your care to an outpatient. They text me every day. So if they have problems at home, I very quickly can get on top of it because I get a text from my patients every day for the first 5 days. Median length of stay went from 81 hours to 27 hours, so it's a day now. Operative time fell to 104 minutes. Patient satisfaction is higher because they go home sooner. All patients had R0 resections, and all of our sleeves of the bronchus and pulmonary artery are done. And we have a YouTube channel. You can just go to YouTube, put in Surfolio surgery. If you put in Surfolio surgery in YouTube, you can see all of our sleeves of the bronchus and the artery. Again, our quality metrics are our lymph nodes, so please get 5N2, 2N1s. And this just shows our length of stay and OR time. So I would conclude, so we have time for questions, that it's really not training or mentoring, but it's also a fellowship. This is a fellowship that we have with one another, and a leadership and counseling one another. It's a commitment on both ends. I'm happy and honored to put the time in if you will put the time in on your end, and we'll help you with your obstacles at home. Because it's very different in Europe with money than it is in the United States. And then it is obtainable if you have access and volume and senior help. And if you really want to do this and you see the value, but you must see the value, and you have the desire and the commitment, it'll work. I've been amazed how many people have failed, mostly because of logistics and money reasons. So there are many challenges to overcome. But you, as the trainee, have to see the value for the patient and surgeons. as I said, we're welcome to have you come either remotely or in person. I like in person, that we can have wine and talk about life. This is my email. Hopefully you can see the email now in my cell phone. And it's my honor to have been a part of this. And this is an ongoing interest. So please let me know how I can help you. Thank you.
Thank you, Robert and Isabel, for these excellent presentations. Maybe you have the perfect setup for training, and of course the dual console is the perfect setup. However, there might be a couple of centers out there where just a single console is present. So what would be your recommendation for these centers, how to optimize training in this center?
So it depends on the person you're training. If the other day we had a general surgeon, PGY3, who was very early in training, and the other console wasn't working. So I'm not going to change our biometric seating and the height every 10 minutes. So I let that person take the ligament down, take the number 9 and number 8, and I let them go up top and take some 2s and 4s. And then I took over and finished that case. So I think it depends on where you are and what you're doing, but we do have to be efficient for the patient's sake. Isabel, what do you do?
Talk to your CEO. No, I think it's really the advantage of the second console is really very, very, very valuable. So if you are at the stage of negotiating to have a robotic platform, this I would highly recommend to include into the package, because it's really very valuable. If it's not there, I would recommend what Surf just said. So you make the easier steps of the operation if it's a very beginner, like taking the ligament or just proceeding, opening the posterior pleura all the way up, and then maybe continue with some lymph nodes. And then as soon as it comes to very vital structures, then maybe take over for safety reason. And the other option could be that you're yourself at the operating theater as the first-hand assistant surgeon at bedside, and you could assist also a little bit better this way.
Yeah, so I'll respond to that one. I think, we want to train our people to be seated surgeons. I'm all for them doing 1 or 2 cases at the bedside, learning how to dock, learning how to troubleshoot the arms. But after that, we try to get everyone to sit. Now we have 44 consoles, right? Or 45. We have 2 in each OR and 1 for simulation. So we're a little spoiled there. But I think if you put them at the bedside too much, then they become a bedside assistant and not a surgeon. So you can learn both ways. And I would prefer to teach on a console, not at the bedside.
Yeah, but I meant the other way around, so that you as the teacher are at the bedside helping.
I think it's difficult because then you can't touch the screen and tell them where to go. So I think that if you have one console, I like to stand at the console and point to it and draw on the interactive console rather than being scrubbed. That's what I'm saying.
Yeah.
You think that robotic surgery is ready, that it should be learned by every thoracic resident and sort of a mandatory form in the curriculum, or you think it should be still some form of subspecialization?
Yeah, well, it may be different in the United States because, our patients don't get charged any more money for robotics. We save money because they go home sooner with the robot, but that may be protocol as opposed to platform. Yes, we think you should learn you should learn before you become a doctor. You have to learn how to do your advanced CPR training. We add robotic simulation to our surgical department of surgery residents coming in Alabama. That was part of their protocol when they came into our department. Same thing with our department now of the cardiothoracic at NYU. We have a separate department for CT surgery here at NYU, and we require our I6s to do the simulation before they come. It's just like CPR training.
Yeah, I think that's, I also have the opinion that now everybody should learn it. But again, it's obviously a question of volume and access to the platform. So I think it's important that first all senior attending surgeons who are the actual trainers are confident. And as soon as all of them are, then everybody should have the opportunity to train also the younger ones.
Another question was, what are actually the limitations, or are there any contraindications to use the robot in lung resections or also esophageal resections?
So, I get that question all the time. How can it be 100%? What if you have, the other day we had a 22 centimeter solitary fibrous tumor of the pleura, 22 centimeters. You can still start off with the robot. I find taking the adhesions down are better. And if it's a non-small cell, I'll start off with a scope and make sure there aren't pleural mets. So that case would count as a planned conversion, but we would start off, and we've done this with a lot of large anterior mediastinal masses. Some we know we're going to go on bypass to look for it, because there's often pleural metastases with these B2 thymomas or these carcinoid of the thymus or these thymic cancers. Those three often have multifocal pleural disease. We'll do a pleurectomy or a biopsy of the pleura, free everything up, and then open. So we still see real benefit starting minimally invasively.
Isabel, you want to add?
Yeah, so I can only echo what you said for the adhesions. I think it's in many cases even easier to take down the adhesions with the robotic approach. However, if it's really like 20 centimeters, obviously the dissection can be done, but then taking it out, it needs to be a small thoracotomy.
Yep.
So it is again a question of how much access you have. So we don't have the robotic platform every day. So I would schedule this case rather somewhere at a different time point and save my slots for the other ones. But feasible is most probably a lot, yeah.
I'm going to add one point about the thoracotomy. So everybody thinks it's binary, thoracotomy or not. I guess I would ask, do you want your ribs spread open for 3 hours? Or is it better to have them spread open for 3 minutes? So do I have data about that? No, but it was me. I'm not sure I want that nerve compressed with a steel retractor. So I would do it robotically, and then at the end, open what I have to remove the tumor. And we also just think it's easier to do the arteries, the vessels, and the adhesions robotically. But even for the big ones, we start off for those reasons minimally invasively. But they're a planned conversion because of the size. Once they get 13 or 14 centimeters, if they're solid, some of these can be, of course, be more viscous, and they're easier to get out.
There was another question at what stage in the training the robotic curriculum should start. I think, Robert, you answered this already more or less prior to starting to practice. Is this also your opinion, Isabel?
The question here about to start as early as possible. Is this
whether to start immediately when starting residency, or whether it should be integrated in the training curriculum probably at a later stage?
No, I think it should be started immediately. But as I said before, I think the senior staff needs to be trained, fully trained, also to be good trainers. So it's you have to have a staff that is solid to teach robotics. And if you have this, you can have every resident for thoracics, I would say. Also customize your access to the platform. I think I can speak for Switzerland at least, and many other European countries. I think none of us is in this luxury situation like you are.
Yeah. Well, that may be true, but as a former vice dean of a medical school, I would go to the first year medical students and say, every one of you should be on that simulator. And then you'd be surprised how many end up going into surgery. So we try to get them early. I really think it's high schools and colleges where we've put simulation training in, just for them to see how much fun you can have to be a surgeon. Because we're losing good people, smart people to surgery because it's such a long road. They'd rather go to finance and be a hedge fund guy and make a lot more money a lot sooner in life. So it's up to us to capture them. So I think it's before medical school. I think it's college and high school, to be honest. They should be learning the simulator then.
Yeah, that's a very good point. Maybe I can just add another comment. We started having medical students access to simulation to rise the interest for our field, because we're facing most probably a problem in our future workforce of thoracic surgery residents. So I think everything we can do in particular those who are at universities and having a lot of medical students, to rise the enthusiasm for thoracic surgery is helpful.
You're coming from dedicated centers where a lot of cases are done robotically. Do you have any data available what the actual percentage of robotic cases is in the US, or any data available in Europe, which is certainly more heterogeneous?
So I'll respond. In the United States, I believe robotics has surpassed VATS now as the preferred minimally platform in the United States, is what I've been told. I'm sure it's not that way in Europe because of the cost and access, but maybe Isabel can respond.
So we have not very granular data about this. Most of the people here will know that we have a ESTS database, and there's also a robotic subsection, and it's all a question of interpretation, how good your data are entered. So at this stage, I would not like to give an answer here about based on the data we have. So it's still more VATS, what Bob just said. Yeah.
Clemens, you see the question about the bulldogs on the PA there?
Yeah, what are you using?
Yeah, so we put a vessel. So when you really again should go to my YouTube channel. I have a YouTube channel, Surfolio Surgery on YouTube, and you'll see we get control, open up the pericardium on both the right and the left side. It's very easy on the left. On the right, it's a little trickier. Lift up the middle lobe, find your middle lobe vein, get it out of the way, and then you can get around the whole PA off of the azigal cable junction. It's not that hard. But we put a big vessel loop around it twice, and then put a bulldog on top of the vessel loop. And we have several of these on our YouTube channel. And then the distal PA, this is very important. And people have given me credit for this to be my idea. This was not my idea. I learned this from Dr. Rendina in Italy. So Dr. Rendina in Italy is smart, and I just copied him. But the distal control of the pulmonary artery should be on the vein. So let's say you're doing a left upper lobe PA sleeve of the bronchus and artery. You get around the main PA, the left PA intrapericardially. You take the left upper lobe vein first because you're doing a left upper lobectomy, and your distal control of the pulmonary artery is not a clamp on the distal PA branch, because then you can't move it and sew it together. It goes on the inferior pulmonary vein, and you do not need to give heparin. Don't give heparin. I've written a paper on this. I've done this in over 93 patients. There's been no clots in those patients. That's clinically significant. So that's the way to do it.
Yeah, that's exactly the case I've been showing. I don't know if you have seen it. It was the main PA in the lower and the inferior vein. And we use tourniquets.
Yep.
You can use vessel loops, but you can also use other thicker Mercilane, for example. And then with we close the tourniquet, and then I do a hemlock clip on it to hold it.
So we do something very similar. So it's very, we put that big white wet clip just on the vessel loop so they don't dangle around and get in your way during the case with the insufflation, and put a bulldog on it. But that works very well. Then you have very little back bleeding from the vein. And right before you put your last suture in the PA to PA arterial anastomosis, you take the venous clamp off first, you let it back bleed, could shoot even a little water so there's no air in the system, and then take the arterial side off, the proximal side second.
Robert, you mentioned you're using a forearm approach. What do you think of less arms, uniportal RATS approaches? Do you have any considerations on that?
Yeah, first of all, I don't like the term RATS. RATS in the United States are not a good thing. So we wrote an article. It's called, completely portal robotic lobectomy, or corporal 4. So we use the term portal robots, or robotic assisted, not RATS. But to me, I've never done an operation where I said, I wish I had one less of my hands in the chest. Never. So I think an 8mm port has very little morbidity. Now, granted, in the back where the ribs are closer together, the nerves a little closer together, it's hard to say what is the pain attributed to that. But I love having the fourth arm. It makes me a much faster, much better surgeon. And I think now that we're using the SP, and we've done SP, we're doing an SP lobe next week. We've done a couple SP thymectomies. You miss that other arm holding the lung up. to be able to get the lymph nodes out quickly. So I still prefer the forearms, but I'm biased, and that's my dogma towards it.
For now, it's actually also until the SP is not yet on the market for thoracics. We have to say that here, right? And using
Yes,
the
we're doing it as part of a study. Yes.
Yeah, exactly. So it's a few centers in the US who are doing now an implementation study. Besides yours, I think it's the Brigham doing a few cases. So we have to mention that at this stage, the SP is not available in Europe, also not, and there is no license for using the normal robot. So please don't start it this way.
Yeah.
No
I was just
license.
answering the question that went from actually using a single arm robot. I missed that fourth arm. We miss it.
So when talking about missing, when you look at the currently available technical features of robotic platforms, which would be a feature you're missing, or what is something you would wish would be available for the next generation of robots? It's probably a tricky question.
No, it's not a tricky question. I don't think anything. I mean, when I look at what we're doing, we're so blessed to have what we have, that you can do every segment, every lobe, and every thymectomy essentially robotically. Now, could you do them better? I would like all 5 millimeter instruments. So I think with the SI, when we had 5 millimeter instruments, I do think their pain was a little bit less, but you needed a 12 millimeter camera with that system. Now we have an 8 millimeter camera. If the XI had 5 millimeter cameras and instruments, I think you'd see a real big benefit for pain of the robotic platform over VATS, which right now I think is hard to prove. But besides that, I don't think one single incision, I don't care if there's 12 incisions, if that doesn't hurt and they're all 5 millimeters. There's something magical about a 5 versus an 8 millimeter incision, cosmetically and pain-wise. That was my experience when I used the SI, but the SI is gone now. Isabel?
I think there are numerous platforms now coming on the market, and I think you and me and some other surgeons here on the panel have had access already. There's most probably no groundbreaking new technique, but some are a little bit more flexible, mobile arms. But I think that's not really, as I said, groundbreaking. There is next generations being promised to have a haptic feedback, which would be quite new, but somebody like Dr. Sofolio, who learned operating with his eyes in the meantime, doesn't need haptic anymore. But maybe for starting it, for new generation surgeons, it might be very nice.
Yeah, and Oliver just made a comment. I'd be careful, Oliver, because just because someone's using a 5 millimeter port doesn't mean they're using preemptive analgesia correctly. Tylenol, gabapentin preemptively. Patients are taking their medicines when they go home. You got to be very careful. There's a lot of things that go into pain besides the number of incisions or the size of the instruments. So we believe in preemptive analgesia and very, very regimented Tylenol and Advil or Tylenol and ibuprofen or Relieve for the first 4 or 5 days when they go home. We think that this does matter.
Okay, so I think we've come to the end of this webinar. I really would like to thank both of you for the excellent presentation and the really nice discussion. Thank you also to all of the participants for taking part and for answering the questions. Unfortunately, due to time constraints, we were not able to answer all the questions. I would look forward to welcome you also to our next webinar on the 17th of April. The topic is thymic tumors, a multidisciplinary panel. We have actually Charlotte Billier from Belgium, Nicolas Girard from France, and Bernhard Moser from Austria, presenting on the radiation oncologist, medical oncologist, and thoracic surgeon's point of view. And I hope you're all gonna participate there again. And for today, I wish you a nice evening and all the best. Bye-bye.
Bye-bye. Thank you.